All right, thanks very much. Dubious distinction to be co-runner-up of this competition. So getting away from congenital pediatric kind of topics, so I hope I don't bore the pediatric cardiologist. These are two adult TAVI cases that illustrate how to contrast how to handle severe AI, because this has really been the Achilles heel, in my opinion, of TAVI. As we go, especially into lower risk surgical patients. So these are contrasting two cases. First case didn't end so well, and we tried to learn and grow from that first case. So this was early in our experience. 80-year-old gentleman who had severe AS and much more. He had severe LV dysfunction, EF of 30%, and this is despite the presence of concomitant moderate mitral regurgitation. He had severe tricuspid regurgitation. He had atrial fibrillation, previous dual chamber pacemaker. His annular dimensions are, as you see there, 28 by 22 with the corresponding perimeter and areas. This is his scout view, and you can see LAO with a little bit of caudal on this projection of the aortogram. You can see that we have a heavily calcified aortic valve, mostly at the leaflets themselves. And there is associated AI, and degree being probably mild to my eye. A temporary wire has been placed as well on the right side of the heart. The teaching has always been that the presence of AI before you do a TAVI will predict a little bit more tolerability of AI after the valve implant, but I think with a little bit of experience you see that may not always be the case. This is where things started going sour very quickly, and it was initially after the balloon aortic valvuloplasty. We use a 20 millimeter balloon, so undersized for the annular dimensions, and a little bit smaller than the LVOT as well. So despite that, the 99 times out of 100 BAV goes just fine. I mean, there used to be a time when we had just this for aortic stenosis, let alone the positioning of a percutaneous stent. But after the BAV, that's when things started going sour. Poor hemodynamic recovery after the pacing was terminated. His pressure was 60 systolic. The anesthetists were supporting him with bolus pressure support, ongoing deterioration, and this is happening. CVP is increasing. Looking at this view, one of the things that we were worried about is that you see the left coronary filling fairly briskly and the right coronary artery filling in fairly late. So we were wondering, gee, what is the significance of that? Is that actually indicative of some sort of embolus, obstruction from the valve? Is it or is it simply because of the mechanical effects of where the catheter sits relative to where the balloon is? The valve was positioned, and you can see here the valve is not deployed, obviously. This is a self-expanding valve, core valve, 29 millimeter valve. Not that it matters because it was never really placed, but it's across the annulus, and you see not only severe AI, which is not surprising. You see this commonly when you position a big, huge truck across an aortic valve. That's impacting the mechanical coaptation of the aortic valve leaflets, but you also see mitral regurgitation here as well. And you can, looking at this film a little bit closely, maybe not on this projection and in this light, the RCA feels a little bit slower than the left. So what is the significance of that? The valve was withdrawn for two reasons. The first is, and this is happening very quickly, the valve was withdrawn so we could get coronary access because we got sidelined by the coronary filling. And it was unclear what was going on. So we wanted to access the coronary. Gee, did we need to do something with the coronary at that time? Are we going to make the problem worse by deploying this metallic scaffold and obstructing the vessel? And we also wanted to know what was going on. Was it a coronary embolus? Is there annular rupture? Is there a wire-induced LV perforation? This is a Lunderquist wire, and you would think that LVH as a response from aortic stenosis would be very difficult to rupture, but when you use stiff wires, all bets are off. Was this rapid pacing with poor LV, or was this just severe AI with a tenuous ventricle to begin with after the BAV? A lot of questions, not a lot of time, very rapid hemodynamic deterioration. You can see from this that there's very little cardiac motion, the dye is stagnant, there's no obvious annular rupture here. CPR was being done at this time, and then so we accessed the coronary, and patient at this time not doing very well. PEA arrest, unable to resuscitate. Ultimately, we thought that the cause of death in this circumstance was severe AI from the BAV, superimposed with rapid pacing on a very poorly functional ventricle. So in retrospect, you always think of these cases and what could I have done better. This is very early in our experience, first time we've dealt with this kind of issue. I think the first mistake in retrospect was that we removed the valve when it was right there. Maybe we should have deployed it and lessened the AI to some degree, even though we may not have completely eliminated it. The second thing is we're doing this in a hybrid suite. Cardiac surgeon is doing this with me. It's being done by committee, and sometimes doing things by committee when you're doing TAVIs is not necessarily a good thing, in the sense that everyone is thinking about what the best way to talk about things, whereas if you're an individual doing things, you act, and there's no time for discussion. And just in terms of the time that how quickly this happened, that discussion was, we were talking very quickly to do this, but the rapid deterioration really prevent a good outcome. So I think removing the valve when it was right there, maybe we should have deployed it. Maybe we should have put this patient on cardiopulmonary bypass, although that is a discussion we have with elderly patients when they're dealing with this kind of circumstance as to whether or not they want to go the full meal deal with sternotomy and surgical aortic valve replacement after cardiopulmonary bypass. Question arises, do you BAV or not BAV a heavily calcified valve in the self-expanding balloon valve space? There has been a move towards away pre-dilating the valve and deploying the valve directly. I think I haven't seen a lot of good evidence for that, but it seems to be a bit of a fad. Would question about in terms of complete valve expansion, and there's also evidence to say that you're just post-dilating the valve more frequently post-deployment. And then there's a legitimate question as should we have done the case. This is an EF of 30% with moderate mitral regurgitation, so take a few points off of that. He had concomitant valve lesions, but sometimes patients don't always match what you're looking at on paper. This gentleman apologized to me one time because he missed one of his appointments. He said, "Sorry, doc, I missed my appointment because I had to change my tire." On his car. So, and I was looking at his imaging and his echo and thinking, how are you not in pulmonary edema right now and more symptomatic at the very least? But my point is that he was not frail and he was very functional. So despite all his valvulopathy and his severe LV dysfunction, we gave him the benefit of the doubt to give it a try at this advanced age. Contrasting this 93-year-old woman, sorry.
Just make a comment.
Yeah.
Did you guys think of just putting them right on support, 10-time support right away? Because even if a patient doesn't want to go for an open heart afterwards or sternotomy, resting them, we've had one case like that, a couple where we rested them for 20 minutes and were able to complete things and they did well. Was there a thought of doing that quickly? And sometimes you always think you can do it in a few minutes and it takes always longer.
Yeah, I think there was a thought, but I mean, it was probably, we were already well into CPR in like 3 minutes into the case. So, and he was already so poorly dysfunctional. In retrospect, maybe that would have been the right thing to do. It was thought of, but we were so, I guess, distracted by the coronary issue that we wanted to go after that first and relieve that problem first. But absolutely, that maybe would have been the right thing to do. In retrospect, we'll never know.
Yeah, just can I comment?
Yeah.
So I'm assuming you CT'd him and everything for the usual way, and the coronary heights, go through the coronary height or who's a candidate or not. So the only thing is, I mean, you already know this. I mean, I was a PI in the core valve, and so sometimes you snort with the coronaries if you knew they were at risk before you put. But if the valve, knowing the coronary is at a certain acceptable height.
Yeah. Oh, yeah. They were well above the 12 millimeter threshold.
And like you were saying, the function was not like that when you had the valve right in position.
The what? Sorry.
Function was not like what it turned out to be once the valve was brought up.
No.
When you saw the air and you saw the function.
Yeah.
And you could still get to the right corner.
Yeah, we could still get to the right coronary artery.
My point is because the cell design is designed so you can still get to that. That was the only thing.
Yeah, in retrospect, it's, yeah.
Air valve, you get to it, it's plenty high, and just do it because you know you've got bad AR.
Yeah, you've got bad AR.
Bypass it.
I would just say, like everything, like you kind of need a checklist for crash after valvuloplasty. There's a checklist you got to run through, like a couple of things. Like you can have, you can have severe aortic, you can have a pericardial effusion that just kind of develops and it just manifests as you're trying to come back. You can have a coronary embolism, and I think it's very important to have that kind of list set up. I have to tell you that recently we went from actually. The nice thing is if you're doing a TAVI through one side and you have vein and artery on the other side, then you can quickly go on to ECMO. But I have to tell you that data, the majority of our vascular complications that we had after the procedure were from the small side.
Yes.
And so we actually went radial, and it's just the way the ICU is taking out sheaths and the residents and everything else. So we started to go radial. So now we only have one big arterial axis and we go radial. The problem is if you ever have to crash on, then that's big troubles, right? So
Yeah.
it's an issue. You're trying to reduce like regular complications to, but you have that one potential issue.
Well, we had a recent similar case where with a poor EF, and we talked about whether we should put the ECMO cannulas in or not, whether we would need them. We had a huge debate, and actually it was a big problem in our MPOR because we were having a debate offline, and we got there that morning. None of the OR nurses knew about the potential plan. We hadn't made the decision until we got there that morning, and they were very uncomfortable with the fact that we wanted to start this case with the ECMO cannulas in.
So I actually made them, and we did the case, and our surgeon and Mark both said, nah, we don't think we need it, and we did so we actually just cannulate, go on, but don't run. And we did the whole case because I didn't have a PDC. You know what I mean? Like,
It was very similar with the EF of 30%, poor coronaries actually, but not bypasses, and he flew through it. Of course, there was severe AI after the valvuloplasty, which I think here was a major contributor to the problem.
yeah, go ahead and
One thing, the right coronary not filling up. I mean, because of heavily calcified, we have seen one case where the valvuloplasty actually obstructed. The calcium actually obstructed the coronary artery. So I was wondering because your right coronary wasn't filling up. I know there was AI, I'm not sure, but I mean that probably could have been.
Yeah, I mean, with the massive hypotension and such, we thought, I mean, maybe there was some more ischemia at play rather than just the right coronary artery. So that's why we shot the left first, and it was all vasoconstricted. But absolutely, I mean, coronary obstruction, embolus, that was all there. I take all these points that are being said, the whole point about cardiopulmonary bypass, and in retrospect, I think maybe we should have done that looking at this case in the light of day. ECMO for us, at least being in Kingston, we would have to shut down our entire cardiac surgery program. So that would be a non-starter as a backup, especially in our institution.
Paul, why don't you continue? Just
Yeah.
so we,
For the interest of time. So this is a 93-year-old woman, severe aortic stenosis, but she had very different constellation of problems. Her ventricle was normal. She had no other significant valvular abnormalities. Her annulus is, as you see there, 23 by 26, 81 and 435 for the perimeter and area measurements. Heavily calcified aortic valve, much like the last time, but now the calcium is extending into the LVOT, and this really obscures the landing zone of the implant. The BAV went very well, 18 millimeters. Then we placed a 29 millimeter core valve, and I'll show you the scout and I'll show you the implant. We did get a left bundle branch block, so never intend to implant the valve more deep, but for whatever reason, sometimes the valve, that's where they end up. Here's the scout, and if I can get it to run, maybe.
it's running, but nothing's happening.
It's not even running here. Let me try that
There
again.
you see it's actually running.
I don't understand. Let me just see.
Go back a slide. And,
Uh-oh. Okay.
let's say there's no AI.
There's no AI.
We take your word for it.
Well, let me tell you a little more. It's heavily calcified. This is not vertebral bodies. In fact, the calcium, they're like big, large nodules of calcium. And the calcium extend into LVOT. The actual left sinus attachment point is way up there. I hope this runs. Oh, fudge. Okay, so now you don't have to take my word for it. I hope this projects. I'm not sure it projects the best in terms of the subtleties, at least. What I'm trying to show here is the coronaries are filling, obviously, and you have a large amount of calcium in the valve itself. The actual leaflet it attaches on the left side way up here, and all this black stuff down here is LVOT calcification. So once again, a heavily calcified aortic valve. In this case, we don't really have any AI, nothing to really speak of here. So, like I said, the BAV, a little bit small BAV, went very well. The dimensions fit with a 29 valve. We put the valve in, and it ended up maybe 6 to 8 millimeters on the non-coronary side, but certainly deep. You can see it's like straddling the LVOT calcification, at least 14 millimeters on the left. And I mean, and part of it is because perhaps you have an obscured landing zone with all that calcium sitting right next to where you want to land the valve on that side. And indeed, we did get a low implant based on the presence of the left bundle branch block, but there was no pacing issues required afterwards. And right after the valve was deployed, again, same kind of issue, but maybe not as brisk as the first gentleman. Hypotension, non-sustained VT, rising CVP, increasing support. This time, a little bit more prepared. We thought we had a little bit more time, mind you, but the echo angio hemodynamics in terms of the LVDP, the AI index, lack of dichotic notch, all was supportive of very severe AI as a cause of this, and didn't show any other perforation or complication related to the initial parts of the deployment. So we tried a little bit of a gutsy move here. The annular annulus is, what did I say it was? 23 by 26. And here we are with two BAVs, 25 and 28. And just to seeing if we can make a difference with expansion of the valve at the annular contact point with all that calcium. You can see here that this 28 balloon is a little bit different size down in the valve frame as opposed to higher up and where the valve flares out, indicating that this is yeah.
By redilating, you thought most of it was not perivalvular valve.
No, we thought it was paravalvular. On the echo was paravalvular, not valve.
Graphically, it didn't look that way.
I don't know how you could tell the difference, quite frankly.
Because you had such a calcified area, and the diameter of the jet met exactly the frame.
But it's circumferential, mind you. Like you're seeing it, that's three-dimensional structure in 2 dimensions. So it's going to seep all around. It's not going to, unless you're like right coaxial or tangential to that plane, you might not see it as a single line. And the echo is showing us there's no valve regurgitation. So anyway, and I think it fits with how this patient actually responded. So we did 2 sequential, arguably aggressive dilatations to see if we could expand this valve with all this calcification there to try to tamp up the paravalvular frame and reduce the AI. It didn't really work that well. There was no real improvement. Angiographically, echo, hemodynamics, all had still severe AI. So shades of this happened just before Halloween, so it was a scary month for us for many reasons, not just the kids' costumes. This was a year later, and shades of the first case were, of course, in the back of everybody's mind, and the patient's not doing well at this time. So no Canadian interventionalist. I wouldn't be a self-respecting coronary interventionalist from Canada without invoking some sort of a coronary explanation. So we thought, gee, are we barking up the wrong tree here? Is this a coronary event? Of course, the screening on the CT and such was that the clearance of the coronaries were well above the annular contact points, so we didn't think that it was a high risk before, but given how this patient was behaving, we thought, and the lack of response to the post-dilatation, we thought, are we barking up the wrong tree altogether? So again, these things are happening very quickly, but the support seems to be holding her in a reasonably stable situation. And this was my first time accessing the coronary through the core valve, and I was dreading doing this, thinking it would be quite difficult to get through the fence to get at where I needed to go, but it was actually surprisingly easy. You could argue that maybe the guide was, if you want to do a complex PCI, this is not sitting in the best position, but it got us the information we needed, where the coronaries didn't really seem to be changed from pre-procedure. So that didn't seem to be the explanation. So what we ended up doing, thinking this is a low implant with all the other evidence that we had thereof, we put in a second core valve, and with this there was rapid improvement. I mean, within like a minute or so, the pressure support was coming down, her blood pressure was going up, the hemodynamics were getting better, her oxygen requirements were coming down. It was dramatic. There was fortunately no coronary obstruction, because effectively what you're doing, the first valve's leaflets are becoming a tube graft, and so we didn't have that issue at all. There was no coronary obstruction. And you can see here, you've all seen here cases of severe AI. You do diagnostic caths. If you're going femoral, you'll see the contrast moving back and forth, that there's really no reflux, though to and fro motion of the contrast when we finish this case, to say that there's no large degree of AI. The runoff is there, and it's not going back and forth, not hanging up in the iliofemoral system. This patient did very well. Extubated in 3 hours, home in 4 days. In 4 days, didn't need a permanent pacemaker. She's NYHA class 2. Follow-up in 1 month. It shows that she has only mild AI. So just a very brief comment on AI post-valve. This was what we thought we were dealing with, but in fact, initially, but for the second case, but in fact, it was because of the valve is deep, and so you have this supra-skirt kind of regurgitation. The others are easy to understand. The size mismatch, of course, although sizing is very much an art form in TAVI. And the other thing is, too shallow, I think, is obvious in the sense that you can understand if there's no coaptation, but we've had a few -1, -2 implants, and the valve can actually serve as a chimney. So even though you have what you think is a -1, -2 implant, it may not necessarily be the end of the world. Of course, you want to make sure that valve doesn't move afterwards, but -1, -2 implants, we've had a couple of those, and I'm pleasantly surprised to see that they've actually done very well hemodynamically and clinically. But this was supraskirt AI, and this is a 3D echo. This is not from this case, where you can see the AI actually happens from above the skirt. And the things that we learned from these cases, the first case was very early in our experience, so I think the fact that we had an internal review afterwards, one of the things that the hospital was forcing us to do is to use different members of support staff, and I don't think these kinds of procedures are conducive to that for good outcomes. We were able to advocate for a consistent team, including anesthesia, echo, nursing, rapidly identify complications, to have that sort of checklist. We're very wary of heavy calcification, and the whole idea that AI, if you have it up front, is protective, I'm not really a big believer in that anymore. Pacing duration, I look at these TAVI cases now, and I think our pacing times, especially for dysfunctional ventricles, has come down by at least 30%. So keeping the pacing duration short, especially with dysfunctional ventricles, to understand the mechanism of AI very quickly. And also I was pleasantly surprised that it's not the end of the world to get access to a coronary after you have a core valve, which has always been a concern of mine as we move into lesser risk patients. BAV or not BAV is a topic of discussion, and looking at cases like this, I think TAVI, any TAVI operator will tell you that the procedure keeps you humble, and looking at complications is an opportunity for improvement. Thanks.